Good evening, organizers, and thank you very much for having me on the program. I'm not sure whether you'll be able to see me. I'm traveling, but it is my great pleasure indeed to invite Dr. Smita Joshi, who I've known for quite a while. She's a senior scientist at Prayas, Pune, and works as a program director and a project consultant at Ruby Hall Clinic, Pune. She's been awarded the UICC Fellowship at IR and the Fogarty Fellowship at Brown University, USA. She has more than 50 publications in national and international peer-reviewed journals, and I know her because she has a passion for cervical cancer screening, and I cannot think of a better person to speak on this particular topic. Dr. Smita, the floor is yours.
Thank you, Dr. Lata, for those kind words. Can I have the option for sharing the slides?
Yes, Dr. We'll just share it here.
And I would also like to thank Dr. Bhagyalakshmi Nayak for giving me this opportunity today to talk to all of you. It's been a wonderful session. So I will be speaking on thermocoagulation for the management of cervical intraepithelial neoplasia. Now, across the world, this terminology, thermocoagulation, it's actually used interchangeably with other names as well. So thermocoagulation is also known as cold coagulation. It is in fact a misnomer because it is heat coagulation. It is used, it is also called as CIN cold coagulator. This is the terminology that was used by Dr. Kurt CIN way back in 1960s. It is also called as cervix coagulator, and recently it is called as thermal ablation, and WHO has acknowledged the fact that this modality uses ablative treatment, and therefore they have recommended us to use thermal ablation. Although even in my presentation, I'll be switching between these two terminologies depending upon the terminology that was used by the authors of the papers, or we have been calling it as cold coagulator because we started using this treatment modality way back in 2010, and we've been using it for the past 10 years since it was introduced to us by IARC, and I must mention Dr. Shankar Narayanan and Dr. Partha Basu and all the screening group at IARC who have been instrumental in driving our program. So although this treatment modality is recently got, there's a lot of interest in using this treatment worldwide. This modality is not really new, as Dr. Usha Saraiya also mentioned. And it was used way back in 1960s by Dr. Kurt CIN. He was a German scientist. And the initial publication about this CIN cold coagulator dates back to 1983 by Dr. Duncan. And subsequently, Dr. Duncan published two important papers. And the first one was about the efficacy of this cold coagulation for the treatment of CIN3 disease. And this was a retrospective analysis of about 1,600 women who were treated for CIN3 disease, and the follow-up was done by cytology. And the primary success rate for the treatment of CIN3 was over 90% at 5 years. The second publication is about the efficacy of CIN cold coagulator for the treatment of CIN1 or 2 disease, again based on very long experience of 13 years, and this was used in a see and treat policy. That means colposcopy and treatment during the same visit, and this analysis also involved more than 1,000 women who were treated for CIN1 or CIN2 disease, and the overall success rate was over 95%. And a few developed CIN3 at follow-up. So we've been listening that all these women who received treatment need a long-term follow-up of almost 20 years subsequently. The most recent meta-analysis of studies that included thermal ablation treatment for the management of CIN included studies from LMICs as well, because initially the treatment modality was more commonly used in Europe, in South America, and with advancing interest in this technology, more and more low and middle income countries have also started using this treatment modality. So 23 studies were included in this meta-analysis that was done by IARC, and this involved more than 10,000 and 6,000 patients treated for CIN2 and CIN3 disease, and the overall success rate was more than 93% for the management of CIN2 plus disease. So for the management of CIN, we have ablative treatment and excisional treatment. So under ablative treatment, we have cryotherapy or thermal ablation. And under excisional treatment, the most commonly used treatment modality is LEDs or LEAP or cold knife conization in certain cases. And there is an ongoing study, which is a randomized controlled trial that is comparing 3 treatment modalities, that is cryotherapy, cold coagulation, and LEAP. And the study is being done in Africa, in Lusaka and Zambia by Dr. Partha Basu and the screening group of IARC. And the pilot phase of this study has already been published, in which 750 women were randomized to either of the 3 treatment modalities. And the success rate was almost similar in all the 3 treatment modalities. The study is still ongoing. So WHO has recently published the guidelines for thermal ablation, and I will quickly go through the guidelines that have been led by the World Health Organization. And the first recommendation is to use either LEDs or cryotherapy or thermal ablation to treat all women with histologically confirmed CIN2 plus disease, provided the lesion is eligible for ablation. And this is the most important aspect to understand, that for treatment with the ablative treatment modality, the lesion has to be eligible, and I'll be talking about the eligibility criteria subsequently. The second recommendation is to use about 100 degree centigrade temperature for 20 to 30 seconds, and we can give as many applications as required to cover the entire transformation zone. So treatment of the entire transformation zone is important, even though we are using ablative treatment or the excisional treatment. The second recommendation is to use ablation in exceptional conditions. That means when the lesion is not eligible for ablation, but when LEDs is not possible or referral to a higher center is not possible, you suspect there is going to be a loss to follow-up. So ablation can be used in exceptional cases when the lesion is not eligible and when LEDs is not possible. The third recommendation is to use either thermal ablation or cryotherapy to treat women in the screen and treat program. And when not eligible for the ablative treatment, LEDs can be used even in the screen and treat program. The fourth recommendation is to not use routinely antibiotics. So routine use of antibiotics is not recommended with either of the 3 treatment modalities unless there is any infection or you suspect that she is likely to develop infection, for example, a patient who is anemic. The fifth recommendation, WHO suggests that trained nurses, midwives, and healthcare workers, as well as physicians, can perform thermal ablation in order to ensure that we provide this access to screening as well as treatment to large number of women. And I'm very happy to mention that our nurses have been using this treatment modality for the past 10 years without any really serious complication or recurrence of disease, and frequent training makes them really perfect. I've also visited Barshi several times, and the nurses at Barshi, Nargis Dasta Cancer Memorial Hospital, they're also very excellent in screening as well as treatment. So as we talk about elimination of cervical cancer, we have to increase the coverage of screening, and it's not possible for the doctors to reach all the places, and it is essential that we train our healthcare workers for screening as well as treatment. And the sixth recommendation mentions that in settings where LEDs is available, use LEDs over ablation for the recurrent disease. So whenever there is a recurrence, if LEDs is possible, that should be preferred over ablation. So principles of treatment of any CIN, either use of ablative treatment or excisional treatment, remain the same. And the first and the important principle is that whole transformation zone must be treated. And the transformation zone is the area between the new squamocolumnar junction and the old squamocolumnar junction. So this entire transformation zone must be treated even if the lesion is present only in one quadrant or two quadrants. The minimum depth of treatment should be around 7 millimeters because most of the lesions, even the high-grade lesions, extend up to 5 to 6 millimeters. And with ablative treatment modality, in 70 to 80% of the cases, we reach the depth of about 5 to 6 millimeters. And surveillance of treated patients is necessary for the next 20 years to see whether there is recurrence, whether there is failure of treatment, or if there is no disease. So there are certain eligibility criteria for ablative treatment, and as we have seen the WHO guidelines, this treatment modality can be used for any grade of CIN. Even CIN3 can be treated by ablative treatment, provided certain eligibility criteria is followed, it is not missed. The first and the important criteria is the lesion should be visible on the ectocervix. It has to be a type 1 transformation zone. In some situations where we are suspecting loss to follow-up or when it is not feasible, even in type 2 transformation zone, we can treat by ablation in order to reduce the loss to follow-up. The lesion should not be extending into the endocervical canal or to the vagina. It should be occupying less than 75% of the ectocervix or less than 75% of the transformation zone. So less than 3 quadrants of the transformation zone should be involved by the lesion if you are planning to treat by ablation. There should be no evidence of suspicion of invasive cancer or any glandular abnormality. Do not treat when there is pelvic inflammatory disease at the time of treatment. However, routine or vaginal discharge, if it is there, the treatment can be done, and you can give some antibiotics following treatment. Otherwise, routinely following routine treatment, antibiotics are not recommended. And the woman should not be menstruating at the time of treatment, and she should not be pregnant. So I'll go through some of the slides to show you how to determine the eligibility for ablative treatment. So in this first slide, this is before application. You see the cervix before application. You can see the squamocolumnar junction here, and this is after application. So you can see an acetoid lesion which is occupying about 1 or 2 quadrants of the cervix. And the lesion is on the ectocervix. It is not extending into the endocervical canal. It is not extending to the vagina, and therefore this lesion is eligible for ablative treatment. Here again, you can see the squamocolumnar junction very nicely. There is probably a low-grade lesion here on the upper lip as well as the lower lip. But the lesion is still not covering the entire TZ, probably covering about 3/4 of the transformation zone. This is after application of Liogold's iodine, and this lesion is eligible for ablative treatment. So you can either use this ablative treatment in a screen and treat program where you're using either VI or an HPV test as a primary screening test, or in the screen see and treat program, or in the biopsy confirmed lesion. So you can take a biopsy from the acetoid lesion near the squamocolumnar junction and from the area which appears more dense acetoid, and then you can immediately treat that lesion, and the histopathology report may be available at a later date, but you have at least treated that lesion. If you look at these two diagrams, here you see the lesion is entering into the endocervical canal. The squamocolumnar junction is not visible. It's the lesion is involving all four quadrants of the cervix and looks like a high-grade lesion. Even in this diagram, the lesion is involving all four quadrants of the cervix. The lesion is entering into the endocervical canal. We cannot see the squamocolumnar junction. So these lesions are not eligible for ablative treatment. So what is important to get very good success rate with the ablative treatment is selection criteria of the patient. And if it is followed, this works really well even in the HIV population. This looks like a benign lesion or a low-grade lesion, or maybe squamous metaplasia. This is after application of acetic acid. There is a small acetovite lesion on the upper lip. There is probably small lesion on the lower lip of the cervix, but the squamocolumnar junction is visible. The lesion is on the ectocervix. This is after application of leucols iodine, and thus the lesion is eligible for treatment with ablation. This ablative treatment, thermal ablative treatment, has got certain advantages over cryotherapy, except for the cost of the instrument. However, cryotherapy requires recurrent expenses for refilling the refrigerant gas, which is not required for thermal ablation. So there are two different companies that are making this thermal ablation unit, about which I'll be talking a little later, but the cost varies between 2 to 4 lakhs. But there is no recurrent cost for the instrument once you have the instrument. The instrument is electricity operated as well as a battery operated version is available. So if you are going to use that in the clinic setting, the electricity operated version works very well. But if it is a field setting, it is better to have a battery operated version. The treatment time with thermal ablation is shorter. For cryotherapy, it is always 3 minutes of freezing, 5 minutes of thawing, and 3 minutes of freezing again. So the entire treatment requires about 15 minutes, because we have to wait for thawing the probe after completing the freeze-thaw-freeze cycle. Whereas with thermal ablation, 20 to 30 seconds of application is sufficient to achieve the required depth of destruction. And we can give multiple overlapping applications. And there's less discomfort with thermal ablation. There's less discharge with the thermal ablation. So there are several advantages over cryotherapy when we are using thermal ablation. So this is the YSAP cervix coagulator. It is made by a German company. This is the switch for switching it on and off. This is the temperature regulator. So here you have the maximum temperature that goes up to 120 degrees centigrade. And as mentioned in the WHO guidelines, about 100 to 105 degrees centigrade temperature is sufficient for ablation, and one single application may be given for 30 seconds. We have been using it for 40 to 45 seconds, but the guidelines mention 30 seconds of application is sufficient, and multiple overlapping applications may be given to cover the entire transformation zone. You also have a display, temperature display here, where we can adjust the temperature, and then this is the probe which can be removed from this tubing. So this is the flat probe, but there are two other probes manufactured by the company. There is one with a nipple, and there is one which has probably the depth of the nipple is slightly more. The one with the nipple has about 5 millimeter size of the nipple. So this is made by the German company, and this is the battery operated version of YSAP cervix coagulator. Recently, for the past 3 or 4 years, Liger thermocoagulator is also available in the market. It is made by a US-based company, and it's a very compact small suitcase in which the entire instrument can be fitted. It is a battery operated version, so you have two batteries that are rechargeable. This is the charging station for the battery, and this is for the connection. This is the main handle of the thermocoagulator, and there are two probes. There are 3 or 4 probes that are available. There is a flat probe, there is one probe with the nipple. So this is the assembled unit, and you have a temperature control here, and the timer can be set for 20 degrees or 30 degrees, 20 seconds or 30 seconds. And there is a small light for visualizing the cervix, and this is the probe, and this probe can be detached from the main unit. Even the battery can be removed, and then you can recharge the battery. Once it is charged, you can use it for 30 or 40 patients. So the procedure of thermal ablation is quite simple. As I have mentioned earlier, you can use it in the screen and treat program or the screen see and treat program, or even for the biopsy confirmed lesions, and any grade of CIN can be treated with this treatment modality. So you ask the woman to empty her bladder. She should be lying in the modified lithotomy position, and then insert a self-retaining bivalve speculum. You should either use Cusco speculum or the Graves speculum. Expose the cervix, apply acetic acid, apply Lugol's iodine. If you have the facility, take a biopsy, and then you can treat that lesion during the same sitting. So here you can see the cervix after application of Lugol's iodine, and the probe is covering the entire lesion here in this case, so there is no need for multiple overlapping applications in this case. This is a second case. This is after application of acetic acid. You can see a low-grade lesion on the lower lip. The entire squamocolumnar junction is visible. This is under the green filter. This is after application of Lugol's iodine. You see lesion on the upper lip as well as the lower lip of the cervix and maybe lateral. And this is after application of the cold coagulator, or this is after thermal ablation treatment. This is how the cervix looks after treatment. Side effects or complications following ablative treatment, either thermal ablation or cryotherapy, are almost the same, and they're extremely rare if the treatment is performed carefully. There could be mild discomfort or pain in lower abdomen. Vasovagal reactions are very rare. Vaginal burns can only occur if you are careless, if the vaginal walls are lax, and if they're coming in between the probe, then you can use a condom, cut it on the closed end, and then put that condom on the speculum, and then insert the speculum so that the vaginal walls do not fall in your vision. Bleeding is again very rare and can occur if you take a biopsy and then treat, but in fact this cold coagulation helps in stopping that bleeding area, or it can occur due to infection and secondary hemorrhage. Pelvic inflammatory disease is very, very rare. We haven't seen more than 1 or 2 cases of PID in the last 10 years, and cervical stenosis is also very rare. Post-treatment instructions following thermal ablation are very important. The discharge that is experienced by women is relatively lesser as compared to cryotherapy, but she should be advised that she should expect some watery discharge or reddish or yellowish discharge. There could be mild cramps in abdomen, which is something similar to the menstrual pain, and they can use a sanitary pad if the discharge is causing a lot of discomfort. The important thing is to avoid sexual intercourse for the next 4 to 6 weeks, but if they cannot really follow abstinence, then they should be advised to encourage the male partner to use male condom as well. And they should report for a follow-up examination 3 weeks after treatment, 6 weeks to 3 months after treatment, and then screening at month 12. So they should report back to the clinic if they have fever for more than 2 days, bleeding for more than 2 days, if there's foul smelling, purulent discharge, or if there's severe pain in abdomen. In our experience, none of them actually had any severe complication following treatment, and all there were very few side effects or complications, and that could be managed very well. As we have been hearing since the first lecture, that follow-up of all women treated for CIN is very, very important, and they need a long-term surveillance of almost about 20 years. So at the follow-up visit, when they come back to you, they should be called between 6 months to 12 months. We call them after a year. So HPV testing is the best option at the follow-up visit. Because it can predict treatment failure or cure of the disease. Co-testing, if it is available, that is again very good. Or if HPV testing and co-testing is not available, then repeat screening with cytology or VIVLE. You can do the routine conventional follow-up if the screening test is abnormal, so colposcopy, biopsy from abnormal areas, and repeat treatment if again the lesion is eligible or LEDS or LEAP is preferred as per the WHO guidelines for the treatment of residual or recurrent lesion. Cleaning and disinfection of the probe of the cold coagulation unit is very, very important, but it is very simple. You can train the healthcare providers to do that. This chart shows cleaning of the probe of the Liger's thermocoagulator. So this probe has been removed from the instrument. There is a cap that comes along with the probe, so we must cap the other end of the probe properly, and you should not allow water to touch that area of the probe. So cap the probe properly, clean the probe with normal saline, and then wash the probe under running tap and water. You can use soap if there is a lot of debris attached to the probe, and then dip the probe in Sidex for 20 to 30 minutes. And after 20 to 30 minutes, you can again wash the probe under running tap and water, again repeat it normal saline and heat it, and then you can reuse it on the next patient. If this Sidex business is not possible in a field clinic, then what is recommended is cleaning the probe with saline and then spirit. You can use mild detergent, use soft cloth or cotton to clean the probe, and then heat the probe at 100 degrees centigrade for 1 minute. And for the Liger thermocoagulator, you can set the heating cycle for 20 or 30 seconds or 40 seconds. So depending upon the setting, you see that the probe is heated for 1 minute. And at this temperature and heating for about a minute, it denatures the protein. So the protein is denatured above 60 degrees centigrade. So you can clean this heated probe if required, and then can reuse it on the next patient. So that was my last slide, and thank you very much.